Hi, Robert Imhoff. I'm the President and CEO of the Maryland Patient Safety Center. It started through an act of the Maryland General Assembly. In 2001, they passed legislation establishing the concept of the Patient Safety Center. In 2003, the actual legislation was passed, and from there, two other nonprofits, the Maryland Hospital Association and the Delmarva Foundation, got together and established the Maryland Patient Safety Center. So in 2007, the Patient Safety Center became an independent nonprofit. The Hospital Association and the Delmarva Foundation, as founding members, had special governance authority. They divested themselves of that in 2007 and allowed the organization to become a wholly independent group. Well, the mission of the center is to make healthcare in Maryland the safest in the nation. And the mission is to, through that, we spread patient safety, the work of patient safety, and support healthcare providers in their efforts to make the safest environment possible for patients. That's one of our premier programs and one of the programs I'm most proud of. That's a program that was established through a collaborative effort with the Johns Hopkins Hospital Armstrong Institute, and it's based on their RISE program, which stands for Resiliency in Stressful Events. This program addresses the second victim. When there's a harm incident within healthcare, the first victim, of course, is the patient. The second victim is the clinical person, the doctor, the nurse, the technician, could be a respiratory therapist. You have individuals who are there to care for and to heal, and when things don't go properly and there's an adverse event, when there's a harm incident with the patient, for example, that causes great psychological stress to that individual. This program applies what we term as psychological first aid to those second victims and helps them get over that initial trauma, that initial stress that occurred through the harm incident.
How's that done?
Through a peer responder program. So the hospitals or the providers, it's just not for hospitals, long-term care facilities. This is very applicable to them. They set up a network of peer responders within the organizations that are on call 24/7. And when there is an incident, the second victim is encouraged to access that program and speak to this peer responder about what occurred, what's going on, and to help them, again, over that hump of psychological stress. We've been involved in things like hand hygiene compliance, falls, prevention of falls in hospital, acute care hospitals, and long-term care facilities. So we collect data within those compartments, as it were. And then we also are working to collect adverse event data that are on occurrences throughout the state. The hand hygiene, I think, is a perfect example. We started that program in 2010 involving 44 of the 45 acute care hospitals in Maryland. We were the only state in the country, and I think still the only state in the country, to have a statewide hand hygiene initiative for acute care. So we started the program with a 72% compliance rate, and when we officially finished the program about 18 months ago, we ended with a 92% compliance rate. So we saw a significant increase in clinical people exercising proper hand hygiene, the goal of which is to reduce hospital-acquired infections. We all know, anecdotally, and also empirically, that proper hand hygiene, whether it be through hand washing with soap and water or using sanitizing gel, reduces the number of germs, bacteria on one's hands. That's way things are most easily transmitted. And when you're going from patient room to patient room, or from one patient to another with an examination, if you're not exercising proper hand hygiene, the possibility of transmission of bacteria and germs is significantly higher. So the success of this program was borne out in the state numbers of hospital-acquired infections. As our compliance rate increased, we saw a decrease in the overall number of hospital-acquired infections. Now, we can't and won't take full credit for that because there are many things that go into that hospital-acquired infection number. But we can say with a very high degree of confidence that we certainly contributed to that decrease in hospital-acquired infections. Because again, we know that hand hygiene is the best defense against transmitting bacteria and germs. We would have been very upset had we seen hand hygiene compliance rate go up and that hospital-acquired infection rate go up also. So fortunately, we saw both measurements go in the correct direction. We're involved in a sepsis prevention, or I should say a sepsis mortality reduction initiative. We have 21 acute care hospitals in Maryland that participate in this program. It discusses best practices around early identification, early treatment of sepsis, all toward reducing mortality with sepsis. Sepsis is one of the top 3 causes of death within Maryland hospitals. If it's not treated quickly and properly, it very easily can lead to death. So we saw that as an initiative, again, by discussing best practices, by bringing in faculty from around the country, and having the hospitals talk about what they do best, what they do well, and also what their challenges are, so that they can learn from other organizations about how to correct those challenges. We're seeing a decrease in that mortality rate.